So, hi Pat.
Hello.
I've got Pat Green with me, and I have specifically come to your office where you're in a care home, Willow Park Care Home in West Yorkshire. And I have come back to you because after having a discussion over a year ago about dementia, I suddenly pieced something together that you had said. And I thought because of your background and your experience, it would be really interesting to capture your thoughts again.
Okay.
So the first thing we're going to do, Pat, is I want you to tell people what your background is, especially with regards to mental health, before you've come into the care home industry.
Right, well, when I left school, I moved to Sheffield, and I moved to Sheffield to do general nursing. And in those days, you did a lot of work. There wasn't university work. There wasn't loads of time in school. There was loads of time on the wards, and you were sent everywhere. So it was during that time that I had experience of Middlewood Hospital, which was a very large asylum in Sheffield, on Middlewood Road at Sheffield. It was absolutely enormous. It had a very, very large driveway, very imposing. As you went up the driveway, they were what were called villas, which were sort of wooden buildings with verandas on, which looked like villas, and people more able would have, well, I suppose what we would call today almost independent living. Almost.
See. And about how many patients would it have there?
In the whole hospital, I think there would have been something like 500.
Wow. So that's like a hospital in itself.
Oh, it was, yes, Middlewood Hospital, yes. And then you went up, there was a large clock tower, and then a typical Victorian building.
Yes.
Very typical. You know, the stonework and the windows and everything were very typical Victorian. Inside, long corridors, very dour in a lot of ways.
Yes.
No charm or homeliness or even love or anything about it.
Yeah.
And there were wards. Obviously the wards were staffed by qualified staff, by auxiliaries, but also some of the people who were detained in the hospital were expected to help too.
Really?
Yes.
And so how many years were you in that system?
Well, I was 3 years, just over 3 years in Sheffield.
Yeah.
But then I got married and didn't work in health. And my husband died. So when my husband died, I moved to Barnsley 30 years ago, and I did my RMN in Barnsley.
Yes.
And I was glad I came to Barnsley because it was a totally different culture. And they do have a totally different outlook on mental health.
Yes.
Which for me was refreshing. I don't know whether it's Barnsley people in general, whether they're perhaps in their own way a little bit mad.
Yeah, right.
And I don't mean that in a derogatory way, but they're not as judgmental.
Right.
They really are not as judgmental.
So in that time, you were working still in mental health?
At that time then, I did my RMN.
Yes.
And yes, I then went to work. We had at Barnsley Hospital a department called the DPM, which was the Department of Psychological Medicine. We had 2 consultant psychiatrists within a separate building from the hospital, 2 consultant psychiatrists, 3 wards, and a day hospital and outpatients clinics.
Yes.
2 of the wards were adult, and 1 ward was elderly. And we also had in Barnsley what was called Kendry Hospital, which to me again was a breath of fresh air. Unfortunately, Kendry now has been downsized and they're not doing the good work that they used to do. But we had a long stay ward, so people with severe dementia, and it was very severe, would be nursed there.
Yes.
We had a functional ward, which dealt with people who had schizophrenia, severe depression, bipolar, things like that. And then we had an organic, which again was specific to dementias, but quite challenging behaviours.
I see. So it was more behavioural, that one. And how was it different from the dementia?
Ward 1, the long stay ward, Ward 1, people were very near end of life or very far advanced.
I see.
So they were doubly incontinent, they were in bed a lot of the time, most of them were hoisted, wheelchairs.
So why
fed.
weren't they in a care home environment?
They did move some people to care homes, and that did happen. We would have people admitted to Kendry Hospital, and yes, they would move on to care homes. And some would stay, and I never really knew who made that decision.
Ah, I see. Interesting.
Obviously, if you move to a care home, then there's a cost involved.
True. Yes, this one, yes, that could have been a funding issue.
It could have been.
Could have been a funding issue.
It could have been. And then we had a respite ward, which in itself was really good how it worked. And then we had a rehabilitation ward.
Interesting.
So we did have people that went home.
Yes.
That had presented at hospital with some form of a mental illness over 65.
Yes.
But they probably had capabilities if they had some physio, in some cases CBT,
yes,
all of those things, and they could go home. The respite ward, again, was very innovative. What we did was we had a diary and we diarised people's respite. So you could have a week, you could have a fortnight, you could have a month.
Yes.
Depending on what your social worker arranged for you.
Yes.
While a patient was in the hospital, obviously the relative would have a rest.
Yes.
So we left them alone to have a rest. When the patient went home, we all had our own caseload. We followed that person to their home and supported the relative
the transition
within their home.
Yes.
Until the next respite visit.
Yes.
So we were always aware of deterioration,
yes,
of extra need, of things like they may become incontinent. Did they need extra funding going in? Did somebody need a sitting service?
Yes, excellent. So then this is what I wanted to capture, that background that you've had with mental health, with dementia and so on. And then you transitioned into the care home system.
I did 30 years ago.
30 years ago.
Yeah,
so
20-something years ago.
And you have seen the growth of dementia, but you think a lot of it is demographic in terms of the ages of patients?
I do. I think in the Yorkshire area, because of the high incidence of heavy engineering or mining, people didn't live as long. So we didn't see a lot of people developing a dementia because they just weren't living long enough to.
Yes.
Miners particularly, in the Barnsley area, the incidence of a miner reaching retirement age was low to start with.
Yes.
With him living much through his retirement, got lower.
Yes.
So it was often
not as much.
You didn't see dementia because they didn't live long enough to develop it.
Now, the reason that I'm here specifically was because over a year ago, when we first were talking about dementia, you had said something that changed the way I viewed dementia. And I am here to try and capture that thought again with what you said about how you can identify patients who are going into the terminal phase of their dementia. Yes,
that there is a definite change, a definite change. The first thing that you will notice, apart from the obvious deterioration, maybe mobility, maybe more incontinent, maybe some behaviours, the inability to recognise even family members, apart from those things that obviously happen with all dementias, there is also this thing where they suddenly, and it appears to be for no reason, lose all interest in food and drink.
Literally, just like that?
Yes. Sometimes it can be gradual, where they're eating less, you're tempting them with more things, particularly sweet things.
Yes.
They can be tempted with sweeties, and you try to do that where they maybe won't eat a dinner with vegetables and meat. They will eat a pudding with custard because it's very sweet. But then even that starts to go.
And you mentioned that what tends to go first? Is it the eating or the drinking?
The drinking goes first.
That's quite remarkable.
The drinking goes first, and it's as if they have no thirst.
So even when you offer them a cup of tea, a cup of water,
No.
not
They may
interested.
take a sip and they'll push you away, or they'll spit it out. At that point, is then getting medication into these people is very difficult too.
Yeah, because you need them to swallow the
You
water.
need them to swallow, that's right. And typical of most of the elderly who reach the dementia stage, they're prone to constipation. You want to get things like aperients down them. Well, they're often mixed in
Yes.
200 mils of water.
Until you'll never get
It's damn nigh an impossibility.
Mm.
The amounts become so minuscule. If you are recording, as my staff would do at that stage, they would start recording food and fluid. And you look at a fluid chart, you can see the minimal amounts.
They're literally just taking sips.
Yeah. Offered 200, drank 10 mils.
Wow. And they have no interest in even asking for something.
No. No.
And about how long after do you find that the hunger goes?
Fairly quickly.
Days, weeks?
Usually the two-ish together, but definitely drinking first.
Yeah.
Definitely drinking first, but very quickly followed by I have no interest in food.
Mm-hmm.
It starts off with the lack of, or the apparent lack of taste.
Mm-hmm.
So, you know, your average meat, 2 veg, and mashed potatoes is of no interest whatsoever. Yes, you can still probably manage to get the sweet.
Yes.
We have, in our kitchen here, we make a special milkshake.
Mm-hmm.
It's made with fortified milk, it has fresh cream in it, we put ice cream in it, we put sugar in it. It's so high calorie, and sometimes we can get that, but that's at the very early stages. That goes quickly too.
And this observation that you had said really stuck with me. And it was only recently that I almost saw the pieces coming together when I was looking at the hypothalamus, with the hunger, the thirst center being connected quite close with the visual and the sleep-wake cycle of the pineal gland in the hypothalamic in the third ventricle. And suddenly it just struck me that all of these things seem to all connect together. And what do you find with regards to sleep and so on? Has the sleep-wake cycle completely gone?
They sleep more,
Yes.
but your expectation is that they would. They're not taking as many nutrients in,
Yes.
so they're quite lethargic. They could be possibly anemic.
Mm-hmm.
You know, you've got all these things going on, but you won't have any energy if you don't eat and
That's
drink.
right, yes. Yes.
So, yes, we see them sleep more and want to sleep more.
Yes.
Whereas they may have been at one time somebody who paced constantly,
Mm-hmm.
somebody who fiddled,
Mm-hmm.
you know, wanted to lift up cushions, wanted to look under ornaments, wanted to poke at things, wanted to see what the neighbour was doing, suddenly seemed to lose all interest in that and become this lethargy seems to come over them.
Really, yes.
And with the lethargy comes less eating and drinking,
Yes.
to the point that now you're sort of looking and thinking, oh dear, I'm losing this battle.
Yes. And then what do you say to the relatives? Because that can be quite difficult.
It's extremely difficult because a relative has an expectation you're a caregiver. In that giving of care, you are trying to get somebody to eat and drink because you want to nurture them.
Yes.
And as a caregiver, that's what you should do. You nurture people.
Yeah.
So it's very difficult for a family member to understand. We invite them to come in and we say, maybe because they know you, you try and feed them.
Mm-hmm.
But often they experience the same problems we have. They'll come back with a full plate and say she hasn't eaten any of it.
Yes.
Or I've got a spoonful down her. So they get an understanding that it's difficult, but a lot of relatives still have almost this, they resent the fact that you're not getting it down.
Yes. Yes. I can.
And I understand that.
Yes. Yes.
I understand that.
Mm-hmm.
You know, if you had a baby who's difficult to feed, you would try absolutely everything, wouldn't you?
Yes.
And eventually you'd succeed.
Mm-hmm.
And they will often ask you, can you take them to hospital and have a drip put up so they can get some fluid?
Yes.
And what we have to try to explain is that's a very short-term solution. Then they come back having a traumatic event. Going to hospital is traumatic for somebody with dementia.
Yeah.
They come back after that traumatic event and you're back to square one.
Yeah.
You can't keep putting somebody in hospital for a short-term fix.
Yes.
It's not going to solve the problem.
And we see that all the time, and it's very difficult to get across to relatives that there is nothing you can do if they will not eat.
No.
Because no matter how much you rehydrate them, they still won't eat.
That's right. And there is nothing. And you do have a sense of failure. Because when you're looking after somebody, that is your aim, to rear them, to make them be well. And you have this sense of failure that you haven't been able to do it. And it's so frustrating. And you will try everything. You will try freezing, things like Fresabin drinks and Ensure drinks. You'll freeze them because sometimes the cold on their lips. Oh, yeah. And then that works once and doesn't work again. And then you'll try spooning things, very tiny teaspoons. Very, very slowly, and that'll work once. And then doesn't work again. So it's almost like they're challenging you. You can try what you want, but I'm not going to eat and drink. And that is so frustrating.
And how do you think, if you could help a relative to understand how to approach that phase, what would you tell them?
Well, we explain everything as I've explained to you, that we've reached a stage now where we are not going to pull any trees up and we're not going to succeed.
Yeah,
we're going to admit failure. We're going to hold our hands up and say, we can't do this. What we can do is we can get this person as comfortable as we possibly can. So if we feel there is distress from dehydration or hunger, we can put anticipatory drugs in place. We can make sure that the person is sedated to the level where they're comfortable. Not necessarily have to be totally sedated and out of it, but comfortable. And that in itself is sometimes something that's hard to accept, because what you're doing then is you're perpetuating what's happening. You're aiding and abetting.
Well, we call it almost advanced care planning.
And that's what we do.
That's right, and it's a critical part of the process, because as much as we are here to support life, we also recognize that everybody will die at some point, and it's how we approach death that's just as important.
I think what's hard for relatives to understand is, if you have a loved one with a terminal illness, you almost have an end date to that terminal illness. Or somebody has a massive heart attack and hasn't been able to be revived. You've had that full stop. When you are actively watching somebody die because they don't eat and drink, it can be an incredibly long process. Depending on the strength of the patient. Some of them can go such a long time. And I think that time is hard for relatives to deal with too. Because obviously you're not actively promoting bringing death forward. You're still promoting life. You're doing everything you can to keep them comfortable, and you sit there at the side of the bed and think, how can they last? It's been now 4 weeks since they ate and drank. How are they still here? And again, that must be a terrible journey for a relative. It's bad for staff.
One of the things I usually say to relatives when I see that in the hospital is I advise them that don't put a time frame on it. Know that every time you leave, it may be the last time. Recognize that it's going to be emotionally draining, so don't add physical tiredness on top of it. Go home, rest, eat, keep living your life, and just recognize that this could be a long process.
We do the same. Go home, get some rest. We'll call you if we think anything's changed. Don't be here 24/7. You can't live that for them. All you'll do is drain yourself. And often you have other family members to look after, and husbands and wives and children and grandchildren to look after. Life has to go on outside of what's happening in that bed. So you talk, but you let them talk. And I think that's the time to start talking about, what's the funniest thing you remember that they did, and what were the good times that you had, because that will bring happy memories. And that's the time to start talking about all those sorts of things. And you know, once you've come to that stage, you know what's happening to that person in that bed, and you think now's the time to talk about their life.
Absolutely.
We're at the end of it, but let's talk about it.
Absolutely.
So that's how we support people. And it's amazing at that point, the stories that families will tell you.
Yes.
How wonderful, and the things that you learn about people that you didn't know.
Yes. Yes.
And you go, oh, wow.
Mm-hmm.
Wow. And that's, I think, while it's the whole thing going on is sad, if you've been told something really wonderful or something really funny or something really moving about the person in the bed, you lightened.
Yes.
So everybody's lightened. So that's how we approach it. And I think that's about person-centred.
Absolutely. I think that is absolutely beautiful. I want to thank you so much, Pat.
You're very welcome.
I think that was incredible, and I hope this is going to be of value to the people who listen.
Oh, thank you. That's very kind of you.